Hello, my name is Dimitrios Athanasiadis, and I'm the Bariatric Research Fellow working with Indiana University. I wanted to thank SAGES for the opportunity to present the work of our team regarding the relationship of patients' age and bariatric outcomes. I have nothing to disclose. As it's already known, obesity is a growing epidemic in the United States. Currently, not only there are no signs of it slowing down, but we anticipate that by 2013, half of the population will be obese, while 1 out of 4 will have severe obesity. In addition, we even know that some states in the US are more susceptible to obesity than others. Obesity pandemic affects all ages and is of paramount importance as it's strongly linked with mortality and comorbidities such as hypertension, diabetes, hyperlipidemia, obstructive sleep apnea, and others. Currently, the most effective and durable method of weight loss is bariatric surgery, which leads to effective comorbidity resolution and increased survival. Even though older patients are heavily affected by obesity, data are conflicting regarding its benefits and whether the outcomes are comparable to those of younger patients. Even though some studies have shown similar weight loss among various age groups, others have failed to show such results. On the contrary, there are studies showing superior comorbidity resolution in adolescents compared to patients with more than 60 years of age, even when adjusting the groups to have similar weight loss. Thus, we aim to assess the short and mid-term outcomes of the most commonly performed bariatric operations, meaning laparoscopic Roux-en-Y gastric bypass and laparoscopic sleeve gastrectomy across the adult age continuum. We conducted a retrospective cohort study of bariatric patients from our prospectively collected database. We even extensively reviewed patients' charts for any data missing from the database. To allow for at least 4 years of follow-up, we elected to include patients from 2011, which is when we started the database, until 2015. Patients were split among age groups according to previous studies in the literature, which finally included patients of less than 30 years of age, 30 to 39, 40 to 49, 50 to 59, and lastly more than 60 years of age. We collected demographics such as years of age, sex, and health insurance, in addition to BMI, weight loss, complications such as reoperations, reinterventions, and 90-day mortality, and comorbidity resolution. Remission of comorbidities was considered when at follow-up their respective medications and devices had been discontinued or they had a normal sleep test study. Regarding the statistical analysis, the groups were compared with ANOVA and chi-square tests. Multivariable binary and linear regressions were performed to investigate whether the difference in age groups was affected by group allocation. We adjusted for potential confounders, including type of operation, sex, and type of insurance. Regarding demographics, we found some differences in the sex and insurance categories that were adjusted further down in the analysis. Specifically, younger patients had higher prevalence of females, while they were more likely to have private insurance compared to the elder patients. Regarding postoperative morbidity, differences were found only in the early postoperative outcomes, as length of stay was prolonged in the elder patients. We observed only 1 death in the first 90 days of our study population, as a 45-year-old patient expired due to pulmonary embolism. Even though our patients had similar BMI in their postoperative years, older patients actually lost less weight as they started with lower BMI values than younger patients. This can be better appreciated by the next figure, in which we can see the difference in the weight loss. This is a weight loss figure where y-axis represents weight loss expressed as difference in BMI, and x-axis represents follow-up years. The first time point is the day of surgery, where weight loss was 0. The more negative the values of the difference in BMI, the higher the weight loss. As we can see, even if in the first year, the more elder patients had less weight loss than their younger counterparts. Specifically, after adjusting for confounders such as sex, type of surgery, and insurance, the 30 to 39-year-old patients lost more weight in the first, second, and third follow-up years compared with patients of over 50 years of age, meaning both 50 to 59 and more than 60. gastric bypass was strongly associated with higher difference in BMI when compared with sleeve patients. Actually, in the first year, the gastric bypass patients lost 3.5 more BMI points than the sleeve patients. In the second year, it was 5.1, third year 5.5, and fourth year 5.2 BMI points. However, sex and type of insurance were not associated with weight loss after controlling for age and type of surgery. This is a figure showing the prevalence of diabetes across the follow-up years. We can appreciate that older patients presented with increased prevalence of diabetes mellitus type 2 compared to the younger patients. Even though older patients started with higher prevalence of diabetes though, after performing multivariable logistic analysis accounting for that, we found that younger patients had higher resolution of diabetes in the follow-up years. More specifically, diabetes 2 resolution during the first year was lower in patients with more than 60 years of age when compared to the 30 to 39-year-old patients, as the odds ratio was less than 1. Specifically, it was 0.69. The odds ratio in the second year was 0.87, while that in the third year was 0.89. Similar results were found for hyperlipidemia outcomes. We found smaller resolution odds ratios between patients more than 50 years old when compared to those of 30 to 39. The odds ratios for hyperlipidemia resolution in the more than 60-year-old patients when compared to the 30 to 39 was 0.6 for the first year, 0.85 for the second year, 0.78 for the third year, and 0.77 for the fourth year. Hyperlipidemia resolution for the 50 to 59-year-old patients compared to the 30 to 39 was similar to those of the first group. Specifically, for the first year, the resolution was 0.72, second year was 0.77, third year was 0.87, and fourth year was 0.8. Again, similar results were observed in the resolution of hypertension between older and younger patients. Patients of more than 50 years of age had lower resolution than patients 30 to 39, similar to the other slides, for all years of follow-up. Obstructive sleep apnea was the only comorbidity in which we did not observe as big of difference between the groups. We only found a difference for the first year of follow-up between 50 to 59 and 30 to 39-year-old patients. In conclusion, we identified that bariatric surgery can be accomplished safely across all age groups with good weight loss up to 4 years after surgery. Nevertheless, younger patients lost more weight and experienced higher resolution of comorbidities. In addition, older age patients with increasing comorbidities may prolong length of stay and convalescence. Finally, it may be inferred that young patients with higher BMI will likely develop advanced comorbidities later, which may result in reduced life expectancy as older patients typically present for bariatric surgery with lower BMI. Thus, performing bariatric surgery earlier will not only provide a greater impact on weight loss and comorbidities, but it will also provide more years to reap its benefits. Thank you very much, and I'm happy to take any questions.